Hey, Dawson. Welcome to the Healthcare Intelligence Podcast. Today, I'm really excited to have Dawson Ballard join us. He is currently a coding auditor and educator at Rush. I'll let him tell us a little bit more about what that meant and what's the day of having the coding piece shared with provider and coder.
Well, I have several specialties that I am involved with that I specifically work with auditing our providers, whether that's physicians, APPs, or any other type of provider that can bill, like social workers, psychologists. And I take questions from them from the field about, hey, we're starting this new program here, or we bought this new piece of equipment to do this procedure. How would we code that? What would the reimbursement around that look like? I do their annual reviews. We audit them annually for primarily E&M, but if it's something like social workers or psychiatrists or psychologists rather, for their psychotherapy codes, and provide feedback and educational opportunities to them if they're overcoding or undercoding, or the documentation just isn't there, or it's a resident and there's no attestation there, but we build a resident service. And then I also educate throughout the year on coding changes, or Medicare changes that have come down, or new payer policies that have been released, or coding updates, those types of things. So I'm constantly always engaged with my providers for the specialties that I am assigned to.
One thing we all know is providers super busy and they may not keep track of all the changes, even though if we told them several times. What's the forum you found most helpful? Like what cadence? How do you make sure things are fixed before they get submitted to the payer? Things like that.
I join each specialty has what they call a monthly team meeting, department meeting, whatever you want to call it. And I'm always invited to those. So I get them collectively as a group and do a presentation of, Cigna has released this new policy that they're going to be down coding all your high level E&Ms, and answer any specific questions there may be about that piece. But we have it ingrained into the back end with the coders, because we don't want the physicians walking into the room looking at the payer and worrying about, I've got to do it this way for this payer. So I educate the providers so when they see that happening, they know it's a payer policy that's doing it, but it's also works on the back end in terms of the policies are up for the particular coders. Plus, we have some edits that are also in place on the back end that if it's, a payer that even though we did this procedure, they only want this modifier. So there's an edit that pops up for the coders on the back end to be able to apply those specific policies as well to get it correct as it goes out the door to the payer.
And when you look at the changes that need to happen, let's talk about some common ones. Maybe they're undercoding a 3 when it should be a 4. What are some common signals you look for in those cases?
Well, I look at the medical necessity of the encounter, number one, because the CPT guidelines from both the AMA and Medicare state that the treatment has to be reflective of the presenting problem. So I look at, you've got a stable chronic condition, hypertension, let's say, but you're coding it a 4. Or you're telling me you spent 35 minutes in the room when all it is stable hypertension. You're telling them to consider the med, or, just continue their meds. And so you have to look at the overall medical necessity of the encounter that, hey, you've only got one stable condition. That's a 3, not a 4. And also around the time elements, that time has to also make sense, that it has to be medically necessary. In other words, that the medical decision making is low, but your time is moderate, there has to be a little bit more detail there as to what you did during that 35 minutes or whatever it is that pushed it from a low to a moderate. I find there's a lot of confusion around that they think because it's a stable condition and I refilled a med, that automatically makes it a 4. It doesn't.
How do you track time? Do you use their schedule, or is there something else you add to make sure the time is up to the spot?
Well, we do look at their schedules. So I've had providers, and not necessarily at Rush, but I'm talking about in my past career, They want those higher RVUs and everything's a 5. I spent 60 minutes with every patient. I saw 20 patients today and I was in there an hour. And you go back and look at their schedule, no, you weren't. So, we do look at their schedules to kind of verify that if they're saying, I spent 35 minutes, that the patient, that it was doable based upon their schedule, I guess is what I'm saying. So we do monitor, we do look at that if need be. And again, we also look at, sometimes I've even had to go back to the provider and say, you're telling me you spent 60 minutes in here, but I look at your schedule and you had 3 patients going on at the same time. So yeah, we do track the time usually through their schedule to make sure that what they're telling us, meshes with, the patients they had, the workload they had that day.
And there are some trickier cases where the coding guidelines diverge, right? Like CPT, Medicare, they do not always go hand in hand for cases like critical care. So how do you handle those differently?
Well, there is, especially with critical care, there is a difference in terms of the time as well. Also, with prolonged services on office visits, especially, CPT has one time, and then Medicare says, nope, it has to be this threshold before we can consider the prolonged service. What we normally do at our hospital is we follow Medicare. Unless we have something written from the payer that says, no, we only follow CPT, we use CMS as the bottom line for everything. And our rationale behind that is if the payer doesn't have a policy around that, then they follow Medicare because they have to follow something, right? So we usually follow Medicare on that, and that is built into our EMR system that, it's pretty much based on what Medicare says, because while CPT and the AMA do have those specific rules, the AMA is not a payer, Medicare is. Yeah. So we follow Medicare, we pretty much follow Medicare rules across the board. Again, unless the payer comes back differently. And I haven't seen that. So we pretty much follow Medicare. Yeah. So we pretty much follow Medicare across the board, and that's built into our edits in our system.
Understood. And since we were talking about policy changes, now it's around October, November. We saw ICD-10 CM updated. Mm-hmm. We saw CPT coming soon. I mean, it's released already. We'll love to learn more about how you, and every year, how do you incorporate these new set of changes into your training for both the coder and the provider?
Well, in terms of CPT, again, I only address the coding changes that are relevant to the specialties that I'm assigned to. So what I do is like, for example, urology has, 10 new codes for January 1 for 2026. Mm-hmm. Some of them are new. One of them is just a revision of a temporary code that has now been made permanent. But how I handle that is I create a presentation that I present specifically to my urologist about, hey, these are the updates for January 1. Here are the codes. Here's your RVUs. And here's the policies around how you would use that, what Medicare says in terms of documentation requirements, modifiers, that kind of stuff. And it's the same thing with ICD-10. Again, I only handle the updates that are relevant to my specialty, unless it's something that would impact all of the specialties. Like we got a new code for diabetes October 1. So I did roll that out to all of the coders because, everybody touches diabetes. But I usually have sessions one-on-one with my providers specifically to the new code sets for their specialties to kind of, put it out there. There are new codes for it. Here's the guidance around it. If there's questions, reach out. And then I also do the same thing with the coding staff as well around not all of the updates, but, the major ones that are out there via email, or if it's major updates, then we would do like a training session. The coders and the auditors meet every Friday. We have an hour session, we kind of like an office hours. And I would do it as part of that to kind of review the updates that are there. And then there are what we call tip sheets that are created for each specialty that are sent both to the provider as well as the coders. So they have those references at their ready, at their hands to use.
Those coder sessions are interesting because they're touching codes every day, and you probably can get feedback from either the payer's rejections or your internal audits. usually what are the case studies that was run through in those sessions? Like, is it more around things people disagree with, like complicated cases, new cases no one's seen before? Like, can you share some examples of that?
Well, the format varies from week to week. Sometimes it's just an open forum that the coders can bring, problems that they're having to the table that we talk through. And then other times it's an actual physical training session to where we will work on, let's say, E&M, and we'll pull up our cases from our providers, our ENOR, and we'll say, this is how the code the provider assigned. Let's break this apart piece by piece, and you tell me what code you would assign. So it's very hands-on with that. And then we open it up for discussion around, everybody thinks it's this. Why do you think it's this, based upon, using the MDM concepts or whatever it may be. Or we also look at charts with diagnosis coding, particularly what we may have found on audit. It was coded this way using this code, but we didn't follow the convention because the guideline says you're also supposed to code this first. So, those types of things where we walk through case studies on that to kind of give the coders a visual, if you will, and then give them the opportunity to ask any specific questions there may be around that.
Makes sense. And then I think this is specialty dependent, but people always ask, how many case steps do a coder code a day?
Well, that's going to be specialty specific. We don't really have a quota, if you will. We don't have a production standard, not that I'm aware of. My boss may correct that, but I'm not aware of having any kind of a production standard. It's going to vary, obviously. The surgeries are going to take a little bit more longer to code, obviously, especially the more complex ones. I would say they probably get, and this may be a low number, I know, but my surgeries may get probably 20, 25 a day. If it's a little bit more easier, like it's a derm with a office procedure, they may hit 50 a day. Okay, so it does vary by specialty and the complexity of the case, obviously, but I'm not aware of there being a production standard, at least not at my hospital, that they have to meet. They have to meet so many a day.
I see. Then how do you divide and conquer your workload? Is it just they had to work through any queue that was booked on schedule? Because there's no, this is the math, and here's how we divide among our staff.
Well, it's just assigned by specialty into their work. So each coder is assigned either one specialty, depending upon how big it is, or sometimes they may tackle two. So we may have one doing derm and one doing pulmonology as well, because they're not that big. So, and the coders are just assigned, and it just comes into their work queue. Now, if it's something as simple as like an office visit, our providers put that in, and because of the volume of office visits that we get, not all of that comes to the coder. Only about 10% of that does for their review. Usually what the provider puts in is generally what goes to the payer, unless it's something like a consultation or something like critical care or something along those lines. It's just divided up by specialty into their specific work queue, and a lot of times they just get, procedures. They do get some of the E&M, but yeah, it's just, I wasn't involved in how it was divided, but it's just divided by it was just divided by their particular, whatever specialty they're assigned to is what they get in their work queue.
And let's talk about technology a little bit. I'm sure you saw a ton of auto coding things in recent years, or even before that, before large language models come up. Like, where do you think, because a lot of the rules can be codified, a lot of feedback can be shared in a more real-time way. Like, what have you seen effective, potentially effective in this world?
Well, definitely AI. I think that, it's here. We keep saying it's coming. It's not. It's here. I have definitely seen AI be very effective in terms of coding the chart or suggesting codes. Maybe I shouldn't say coding the chart, but suggesting codes that the coders may have overlooked, or it's been coded and it goes back to our CAC for a second set of eyes. And again, stuff we may have overlooked. I've seen software that can provide us very detailed, robust data They can, narrow it down to all the unspecified codes that this provider has used in a month's time frame. So we know we need to target education specifically around that. Or it can give us a little bit more data in terms of denials by payer, denials by provider, money that is being left on the table because they've undercoded, and we're able to, drill it down to dollars and cents that because you overcoded, here's what you missed out in terms of reimbursement. So it's come a long way. We don't have to do the math on our own anymore.
No more Excel crunching.
No more Excel. No more Excel. And it's definitely come a long way to actually, and you can modify it pretty much to give you whatever kind of data you want. So it's definitely been a plus, and it's come a long way to give you instantaneous data pretty much. And I'm all big fan of it. So
How does coder, so you alluded to the fact that it can catch things coders miss, right? Are those feedback
mhm.
done in real time? Do they sit together a day and just fast review all of it? Like, how is the workflow like?
Well, it would be done in real time. So let's say it's after the
Hmm.
fact. Let's say it's been coded, and then it goes back into your CAC or autonomous coding, whatever it is, for like a second set of eyes. Then it happens instantaneous. The system would scan the chart, and then it would be pushed back to the coder some way into like an instant messaging or into their work queue or something along those lines that say, the system has identified you missed this, this, and this. And usually it's minor things like SDOH or something along those lines, but it's usually pretty instantaneous feedback that once it goes into the system, either before or
Hmm.
after, but once it goes into the system, it's usually, instantaneously pushed right back to the coder with immediate feedback. So they know to go in and add those codes or go in to look at, you didn't follow the convention here or something along those lines. So it's pretty instantaneous.
Has it gone to the providers yet?
No, we are still in the process of finalizing things for our program, but there are some parts of AI that have gone, to my understanding, that providers are using in terms of treatment and
Hmm.
diagnosis. So like punch in diabetes, let's say, and it will suggest, you know, what's their A1, if their A1C levels are this, we might recommend you do this kind of thing. So I know that piece of it is out to the providers in terms of that, but in terms of like a coding piece, no, we're not there
Makes
yet.
sense. I think like coder is the experts to verify it first. And once you
Yeah,
finalize it, you can ship it to a broader audience.
exactly. Exactly.
And we talked about a lot of things from the EMM, the changes, how the workflow flows, and what's going to be different tomorrow and today. If there's one thing you want to share with your colleague, your peers about just the coding world, what would that be?
Don't be afraid of the technology. It's here. Utilize it. It will make your workflow a lot easier. When it comes to E&M, particularly, tread lightly with your providers. Now, I'm not saying hold their hands, but you have to understand they didn't go to med school to be coders. That was rarely taught to them. So you kind of have to break it down in simple terms, in terms of E&M, so they have a better understanding of what meets a 4 versus what meets a 5 versus what meets a 3. They're not coders. Now, some of them may have a good grasp of it when they get out of med school. I've met some of them, but they're there to practice medicine, they're not there to code. So you want to approach your education with your providers in simple terms, but you don't want to overwhelm them with tons of information either. You just want to break it down in very simple, easy terms so that they can understand what's a 3, what's a 4. uh, I try to do that with my providers. I provide a clinical example and then I break it down piece by piece. You coded it a 4. Let me show you why it's not a 4, in other words. And I break the chart apart. So, tread lightly with your providers, use very simple terms with them to kind of break it down. Again, don't hold their hand. They need to be held accountable, but still, don't overwhelm them with tons of CPT says this and Cigna says this and Aetna says this. They don't process that. Maybe that's the wrong term, but you
They
know what I
don't
mean. It overwhelms their mind. So yeah, I would say approach it in very simple terms. Give them the resources, but don't overwhelm them either. Break it down for them in a language that they can understand and apply that to their day-to-day setting.
Awesome. Well, thank you for joining us today, Dawson. It's an honor to have you, and we look forward to getting back on the pod next time when there's new changes on coding and talk more about that.
Absolutely. Thank you for having me. It was my pleasure.